Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Hello, everyone, and welcome to the 2024 Lymphatic Education and Research Network online symposium series. My name is Boukovalas. I'm a board-certified plastic surgeon and supervisor of the lymphedema program at the University of Tennessee Medical Center in Knoxville. It's obviously a great honor and pleasure to be presenting today, and special thanks to LE&RN for the invitation to give this presentation. So the topic of my talk is a little different than previous ones. We had many experts giving talks about the actual surgeries, but today I will be talking to you about building a comprehensive lymphedema program in a rural area. Please keep in mind that there will be some time for questions at the end of the presentation, so feel free to write your comments in the Q&A box. On behalf of LE&RN, I would like to thank our sponsors for their generous support, make this series possible. And an important disclaimer for LE&RN that this is just my experience. This is not meant to be a consultation. So for those of you that have healthcare concerns, I would recommend reach out to your local healthcare providers to talk about this. And I have no financial disclosures pertinent to this talk. So let me tell you a few things about me, my background, and what are we going to be talking about today. So I was born and raised in Greece, in case you're wondering where the accent comes from. And then I moved on with my surgical training in the United States, in Philadelphia, then Galveston, Houston, and finally I pursued a microsurgical fellowship at MD Anderson Cancer Center in Houston. And that's where I learned lymphatic surgery, how to perform the super microvascular procedures, and I got more exposure in how to take care of patients with lymphatic disorders. Of course, MD Anderson is a big cancer institute. It has multiple microsurgeons, a lot of resources, one-stop shop, multiple therapists, great protocols. And this is the model that I was taught and what I was exposed to. And then I was recruited and I joined the University of Tennessee Medical Center, which is located in Knoxville, which is located in East Tennessee. And even though our hospital is big, it's 700 hospital bed, level 1 trauma center, it really serves a very diverse population. And when I moved here and I was asked to build a lymphedema program, there were very few resources. So I think the focus of today's talk is not really to get in much depth in the clinical side of things, but I was asked to share my experience. How did we start the program? What barriers did we find? How did we manage to navigate the whole process? Where are we today? And what do the next steps look like? So when I first interviewed, I asked, okay, you want me to build a lymphedema program. What do you currently have in place? And there was a nurse practitioner at the Cancer Institute that was providing some care to the breast cancer patients. And there were two therapists that were certified, but they were providing other type of physical therapy in addition to lymphedema care. And really that was it. There was not a lot of infrastructure as expected. And so basically we had to start from the ground up. Of course, I didn't want to reinvent the wheel. I talked to my mentors. I looked up the literature. I really liked the model of Dr. Singhal's program at Harvard and Boston. And I really liked the idea of the three pillars with the lymphedema treatment clinic, with the coordinator and the therapist around her, and then the lymphatic medicine component with cardiology, vascular medicine, nutrition, all the other specialties that come in for the the non-surgical, I guess, management, and then lymphatic surgery, of course, that would provide surgical options for lymphedema care. During my contract negotiation, I thought it would be important to ask for certain things that I thought would be necessary. We purchased 2 SOZO devices and a perometer for diagnostic equipment. We were able to secure a microscope with ICG capabilities and instruments for the actual surgeries. I requested and I got a research coordinator to help with basically building a little bit the research part of it to follow our outcomes and really try to get some data from a part of the country and a type of program that really not much has been published before in a more rural setting. And then from a clinical standpoint, I thought, okay, well, there's not much going on right now. The nurse practitioner that was part of the Cancer Institute became our research, our lymphedema coordinator. So it kind of made sense in my mind to start small, take care of upper extremity lymphedema patients that more related to oncologic reasons. So the vast majority of the patients initially were breast cancer related. And then we built our lymphedema treatment protocols. We soon after started performing the prophylactic lymphedema surgeries, and we built these protocols as well. And then, of course, before we even got to that point, there was a ton of education that needed to take place because I was not even taught in medical school a ton about the lymphatic system. So how can I expect the healthcare providers in the community to know about it, especially with all the breakthroughs and the innovation that has happened the past decades? So I realized that there was not a lot of awareness, not even between physicians. So there were a lot of talks and presentations, smaller groups, larger groups, patient representative groups. I really tried to educate first, but then also kind of start building some relationships. And of course, leadership is important because if my vision is not aligned with the institutions and leadership vision, then there's going to be a problem for sure coming up. So that's where we're today. We've built a multidisciplinary group. We have our therapists, surgical oncologists, osteopathic medicine, lymphatic medicine, and of course, leadership and stakeholders that are continued with their continued support to continue with the program. Our program, so I joined the institution in January 2021, and it really took me about 9 to 10 months to really work on infrastructure. I thought I'll come in and start doing surgeries, right? I was a young microsurgeon, still a young microsurgeon, but I was just super excited to just, hit the road running. But I realized that I first had to work on the infrastructure. So after putting all these things in line, we launched our website in November of 2021. As I said earlier, we start only with breast cancer-related lymphedema patients, and then later on, a couple of years later, we expanded to lower extremity lymphedema. And the program is still hosted under the Cancer Institute in our hospital. This is our patient evaluation algorithm, which is not very different with previous algorithms published in the literature and from other bigger institutions. We provide routine patient evaluation. Actually, we're doing a lot of screening because we realized with limited resources, we want to make the trips of the patients and also our time valuable. So there's a lot of screening with reviewing records, etc. But we offer objective measurements with the SOZO and the perometer. We have imaging studies available, lymphocytography, SPECT-CT, venous duplex, and we're currently working on building our MR lymphangiography protocols. I perform a lot of ICG lymphangiography. We do have the equipment, and I think it's really helpful for diagnosis, staging, and obviously surgical planning to see who is candidate for certain operations. I will talk about in a little bit. Physical therapy is critical. It's first line, and sometimes the only thing sometimes we can offer for some patients. It's critical for prehabilitation, but also for post-op recovery. And I will say there's going to be a lot of discussion about physical therapy and how I navigated that process, because the volume that we had, the needs of our patients were not met basically by the services provided by our institution. We had to make a decision: do we hire more therapists? Do we work with the community? So that's going to be a big discussion that I will dive a little deeper in a little bit later during the presentation. In terms of surgical treatments, again, this is not the main focus of the talk, but I just want to present what's available and what do we offer. We have physiologic procedures, which include the lymphovenous anastomosis or lymphovenous bypass surgery, and the vascularized lymph node transfer or lymph node transplant. And these two techniques try to address really the dysfunctional lymphatic system and really try to address the actual problem. And then we have debulking techniques with specialized type of liposuction and direct excision. This is a picture that I designed. I think it's very helpful for our patients, and we have it on our website. I like the analogy of lymphedema with a blocked highway. We don't have toll stations in East Tennessee on I-40, but I think people get the message. We can either reroute the flow or the traffic through the feeder road, equivalent for the LVA surgery or LVB, or we just reestablish the traffic flow circulation through the main highway by bringing new lymph nodes, equivalent with a lymph node transplant. These are just some pictures, schematics of how an LVA surgery is being done. It's minimally invasive. This is how the small lymphatic channels that are being reconnected with little veins look under the microscope. And here you can see how small the incisions are. These are some examples of the lymph node transplant surgery. Again, we take lymph nodes from one part of the body and we transplant them where the original problem was. My favorite technique is using the omentum as a donor site, meaning we can take lymph nodes from different parts of the body, but I do like the omentum because there is a very small risk of creating a problem or causing lymphedema in the abdomen. So donor site morbidity is minimal, and also it provides a dual blood flow, which means that we have a lot of lymph nodes with two sets of blood vessels. So technically we can do two sets of lymph node transplants in the same surgery. Hopefully nobody's eating lunch currently, even though it's about lunchtime here. You can see how we can harvest the omentum laparoscopically, and then we can reconnect the blood vessels in the axilla or the groin or elsewhere. And then you can see some intraoperative pictures, how we check the blood flow, and then how we can actually design a second flap. In this case, we have the main omentum in the axilla, and then a small piece of lymph nodes hooked up on the branch of radial artery down the forearm, and we call it a dual level transfer. That's the final closure. There are other areas where we can take lymph nodes from. Supraclavicular lymph nodes is another good site that's pretty popular. That was a young patient. She had lower extremity lymphedema, and this is her before and after, 18 months after surgery. Finally, we have debulking techniques, which are actually very, very important, have a great value in our practice. We do the suction-assisted protein lipectomy and direct excision. Again, we're not going to get into much detail into these topics here, but these are just some representative patients with good results. These are only with one session of supple liposuction for both of these patients. Another passion of mine is actually immediate lymphatic reconstruction, which represents a specialized type of a lymphovenous anastomosis. It's the same concept, but we do that preemptively, basically to prevent development of lymphedema in a patient that will undergo removal of the lymph nodes, most commonly breast cancer patients with metastatic disease that need to have a full axillary lymph node dissection. There's a lot of data. We really try to eliminate and cure lymphedema this way, but we definitely decrease the risk of developing lymphedema down the road. And these are some intraoperative pictures, and you can see how the lymphatic channels are being visualized under the microscope. Today, yes, we will talk about how we built our program, but I want to highlight that on top of this, my job is also to stay on the forefront of our specialty. I may have just graduated 4 years from fellowship, but there are still a lot of new techniques that come out. So for instance, I'm now routinely use a vein graft for my immediate lymphatic reconstructions. Since we can bring a little piece of vein from the thigh and include some one-way valves in case there's a lot of backflow on the vein that we try to reconnect to bypass the flow. That I did not come up with that. There are great experts that have published this before, but these are some intraoperative pictures. That's the inner thigh of this patient. And here you can see how we have actually found the lymphatic channels that drain the arm that had to be divided and cut during the axillary lymph node dissection. And we have connected that vein graft that successfully then brings the lymphatic fluid into a branch of the axillary vein, and basically it's a highway straight back to the heart. Let's take a few minutes to talk about how this program has evolved, because something I did not anticipate when I first came here, I thought I'll just copy the MD Anderson, protocols and pretty much do what my mentors were doing back in Houston, just do them in Knoxville, Tennessee, where, well, it didn't work this way. So let me tell you a few things about at least the surgical part of it. So for the LVA, lymphovenous anastomosis surgery, I thought I would be doing more of those. Sadly, I think because there was no care provided for forever in this region, and people didn't really have a lot of awareness, even their providers, to send them to a big center. Most of the patients I see have more advanced disease and they have no targets on ICG. So sadly, I have many patients that I'd love to perform that particular type of surgery, but they're not good candidates for. The other problem with the LVA is that you need strict compliance with physical therapy after surgery. And I've had difficulty with our patient population to ensure that they will follow up and they will be religious about elevation, compression, etc. So there are some barriers here, and that has affected the number of patients that have received this surgery. And right now, I'll show you some data later. Most of my LVAs are in the immediate setting for immediate lymphatic reconstruction. For the lymph node transplants, actually, as I said earlier, I like the momentum for those patients that it's available and they didn't have massive intra-abdominal surgeries, etc. But it's pretty appealing for some patients because we keep them in the hospital for a few days. And then there's not a ton of therapy that is required immediately after surgery. I mean, we want to provide some compression, but you really wait until the lymph nodes, start creating a new network of lymphatic channels. So it really needs less care, at least in my experience. So that has worked actually very nicely in our institution. I've done a bunch of those lymph node transplants. For lower extremity patients, I think debulking techniques and some lymph node transplants have been primarily the surgical treatments that have been provided and offered to the patients. And debulking and suction assisted protein lipectomy, I think it's very important to address any evidence of chronic disease with deposition of fat cells and fibrosis and sclerosis and minimize the inflammatory burden. So I've definitely incorporated that more in my practice. And for those patients that have both a fluid dominant lymphedema, but also have some evidence of chronic disease, I prefer to do the debulking surgery up front to minimize that inflammatory burden and decompress the extremity volume-wise and from a fibrosis standpoint, and then come back and do my physiologic surgery. And that is similar to other centers as well. This is not just my protocols here. And as I said earlier, I finished fellowship, and all I want to do is like these new super fancy procedures. And I still have to remind myself that not everybody needs and qualifies for microsurgical lymphatic surgery. Coordinating with the lymphedema therapist was a big teaching point for me, and it's a dynamic process still. I realized that I had to do a lot of customization of the postoperative protocol for these patients. In my mind, you just see the numbers, you just pick what's the right surgery, and then you just do it. Well, it's not that simple because of the limited resources. Sometimes patients didn't have access to a car or compression garments. There were social factors. There were a lot of other things that came into the equation. So I learned early on I had to really tailor the post-op protocols and really work with therapists, not only in my institution, but also outside, to really provide the appropriate care in order to have best outcomes. Because if you do a perfect surgery, but the patient cannot go back to their therapist or don't have the appropriate garment for compression, then basically it's going to be a waste. And I really realized that the immediate lymphatic reconstruction requires almost zero resources from a manpower standpoint. You need to have a microscope and you need to have the protocols in place, but basically most of the work is being done right at the same time in the OR, at the same time with a ablative surgery, and it doesn't require a lot of post-op care, and you hope that, of course, this patient will never develop lymphedema. So I think that was a huge area that I boosted my practice, because if you can prevent lymphedema from ever happening, I mean, that's the best way to deal with it. So where are we today? I think we're the first comprehensive program in Tennessee. Vanderbilt has a beautiful program. They recently expanded the range of surgeries that they provide, and we work very collaboratively together. Here at UT, we have a multidisciplinary team, as I showed you earlier, state-of-the-art equipment. We had multiple referrals from the region, but also out of state. We perform prophylactic and therapeutic lymphedema surgery, and have developed a relationship with industry, and we had research grants that we have gotten to support our practice. Beyond UT, we have a large network of external physical therapists, and I realized that this is probably not how most programs function. I would love to have multiple therapists available or dedicated 24/7 while when we're doing the surgeries for inpatient, outpatient, to help with our patients. But I realized that the institution was not willing to invest in that. And then I realized that there were some great lymphedema therapists out there that have been working for years, providing excellent care. And I realized, well, why invest in something that, especially when resources are limited, when you can actually utilize already existing resources in the community? And that actually turned out to be a very positive relationship and experience, because then they didn't feel, oh, this new guy came in town, wants to take over. We've been doing that for years, struggling with all the limitations, and all the difficulties that, this condition comes with. But to the contrary, we just created a platform to work all together. I've shared my protocols. They know what I expect. We are on cell phone communication, and I know where each one of my patients go for therapy before and after surgery. And this way I can ensure that they will have better care before and after surgery. And the other thing is that our patients did not want to come to UT for their therapy. So that was another whole story. I realized, so I came from Houston. In my mind, UT Medical Center, yes, it's a big hospital, but very manageable in terms of size and everything else. Well, for many of our patients, it feels chaotic, it feels huge, they get lost, they don't have parking, they just don't want to travel, so they prefer actually to stay to their established therapist to work with. So that was a huge, again, learning experience for me. We have expanded our referral base to out of state. I've seen patients from North Carolina, West Virginia, Kentucky, Alabama, and Georgia. And of course, we've worked on education and community service. We launched the Learn Tennessee chapter in 2022. And we're conducting actively research, again, based on the resources we have. I'll show you a few slides how the program has expanded in terms of referrals. That was 2021. We just captured just a few patients at the tail end of the year, but that's 2022. That's 2023. You see the dots are getting a little more dense, and this is only half year of 2024. So we're projected to have many more referrals as the word kind of goes out. And this map doesn't even include some referrals from out of state that I've already seen patients from. And this is a heat map that kind of shows the distribution. So a lot of regional referrals and patient population, but we also have people that travel from out of state to see us. For the purpose of this presentation, I collected some data because at the end of the day, everybody needs to have numbers. So I pulled some data from January of 2022 to June of 2024, and we have a little over 300 referrals at that time. Many patients have already received surgery, but as you can see, we have 40% of the patients are still waiting to be seen. And this is, it hurts me. Again, we try to do as much as we can, but there's a difference, I think, between our program and maybe a dedicated program in a much bigger academic institution with more resources where we can just open more clinic space, have more of our time, etc. That's a relatively busy table, but I'll focus your attention on the etiology of lymphedema patients that we have seen so far. 75% of those patients were breast cancer-related lymphedema, and as expected, about almost 80% of our patients have been upper extremity lymphedema patients. And interestingly, which I didn't know what the number was until I collected the data, but I knew it was a very high percentage. Over half of the patients had never been referred to physical therapists before being referred to our clinic. I mean, I had patients that came in, they had no idea why they were seeing me for. So I guess education to the healthcare provider system worked because somebody pulled the trigger or sent them to us, but there were some patients that had no idea they even had lymphedema. In terms of surgical data, you will see that I have done actually more immediate lymphatic reconstructions than delayed. Only a third of the delayed reconstructions were LVAs. I've done a few of the lymph node transplants. And as I was saying earlier, 40% of the patients that got an ICG had no targets for a lymphovenous anastomosis bypass surgery. And here I've collected some, I thought, interesting data on insurance coverage and reimbursement. And we always work with insurance. We always send pre-authorization because we know that reimbursement and even insurance coverage is very variable, especially in Tennessee. So all the patients that proceeded with surgery had the approved pre-authorization. We still got 17% of our delayed reconstruction patients that we received zero reimbursement from insurance. And then you can see that the average percentage of surgeon fee that was covered by the insurance was barely 30%, a little higher for the immediate lymphatic reconstruction, lower for the delayed lymphatic reconstruction. So reimbursement remains sadly a big problem. These are some graphs that show I guess with the evolution of the progression of the patient evaluations and surgeries performed. And you might see this graph, 2024 is only half year. We're already actually exceeded the the second half. So far, all the previous numbers, so we're projected to be much higher for this year. But you see this graph, you may say, oh, okay, great. This program is growing. They're doing more surgeries, looking good. Well, I broke it down, but I know what we have gone through the past 3 years, and I know what things have impacted us. And I did a little further digging around, and I basically broke this down to quarters. And I just want you to see that this is not a linear line. And the reason why I'm showing you this is because there were sentinel events that corresponded to these dips and drops in the numbers of patient evaluations and different surgeries performed. So for instance, that first drop there was our lymphedema coordinator had to take a leave of absence for a few months for health-related issues, which can happen to anybody. But you can see that basically completely shut down our program actually for a few months. And then more recently, you can see a dip both into a drop both into patient evaluation surgery performed, because that timing corresponded to me being out on paternity leave, and our coordinator again being pulled to cover more the surgical oncology practice because they had lost an APP and they had to prioritize services. Why do I think this is important? Because basically the program is run by 2 people, and we don't have the depth and the manpower. So unfortunately, we had to tell patients that very sorry, but we're not seeing you patients right now. And that has contributed to all these patients that are still waiting to be seen, because unfortunately, we just didn't have the ability to see patients. So I think this is where resource availability is being captured, because you can look at the numbers overall. You might say, great, you've done some good stuff, but I think that shows how much things that can happen to everybody in every practice actually really impacted our service and our program. And this is the number of ILRs that you see. They have really increased, especially in the past year. That's again only half a year. I'm working on some research projects. We're able to secure a seed grant from the Cancer Institute to look into our clinical outcomes, quality of life, and financial toxicity. I want to make sure that, exactly because protocols might be a little different and our patient population is different, that surgeries are still working in a different setting outside MD Anderson and Harvard and Chicago and MSK and all the other great programs that we have in the country and internationally. And then we were able to secure an NIH grant looking into financial toxicity and emotional well-being for breast cancer related lymphedema and breast cancer patients and their families. On top of that, I have some collaborations with UT. We're looking into some artificial intelligence applications in lymphedema. I think it would be great if we can find a way to predict who is going to get lymphedema, because that can actually guide not only patient counseling, but potentially offer the prophylactic, the immediate lymphatic reconstruction in oncologic patients. And next step will be incorporating some MRIs and try to teach the system, see if we can get better predictive models. And that's an ongoing collaboration with UT and the Oak Ridge National Laboratory. The Tennessee chapter was launched in 2022. We're very excited about that. We're still expanding. Last year, we did our first World Lymphedema Day symposium with great success. We had experts from 3 different institutions from the state to present, and we have more events coming up this year. Well, next year. So I think where it all boils down to identify what barriers and challenges we had to overcome. And I think, first of all, start with the patient population. We know that there are different settings in the more urban setting and the more rural setting. Sadly, patients get lymphedema in rural areas as well. And sadly, many of our patients have limited access to care. When I first started, patients didn't, I mean, I would see patients, they didn't know what their diagnosis was. They had no garments, they had nothing. So I realized that I had to work at a different level before I jump in and start doing surgery. Many patients have a different sense of distance to the hospital. That's what I learned. They just don't want to come to the big hospital, so we're trying to find ways to mitigate that. I think it's very important to set reasonable goals and expectations, because when I first came here, there was this enthusiasm and huge excitement, which was so humbling and satisfying for me. But then I started seeing patients. I realized that the expectation was that I had the cure for their lymphedema that they have been living with for 30 years. And there were some hard conversations, but also I identified that it's great to educate healthcare providers and other groups on what we can offer, but I think you also have to help them identify who would be a good candidate to be referred or eventually have surgery, because I realized that maybe I could have done a little better job in that, and that would have saved probably some visits or these uncomfortable conversations that, sorry, there's not a lot I can do for you at this stage. You have chronic disease. So this is something I learned from that process. Tailoring the surgical treatment is, I think, critical. I talked about earlier, it's not only the LDEX and the volumetric difference and the CTAs and the SPECT-CTs, ICG, that's all great. But I realized that for where I practice, if you don't know what job they're doing, there are some patients that have 3 jobs. They cannot take 4 weeks off. So I have to explain to them what the expectations are and work around their schedule and their lives to find the best treatment option. And then, of course, the post-op care, as we discussed earlier, with collaboration with, I think, the external physical therapists, that has been actually a huge part recently, and I had some great outcomes. As long as we have identified this therapist and we know that they can provide good care, and then we have met together, they have seen, actually I've brought the therapist before I even send the patient. I bring them to the hospital, they shadow me, they see the surgery, then we talk about protocols, and then we start building a relationship. And that has worked really nicely. Limited resources is an understatement. I think healthcare is in crisis in general. Healthcare systems are struggling from many aspects, but especially for a program that, quite frankly, it's not lucrative, doesn't make money most of the times. It's hard for an institution to invest starting a big program. So I think it's very important for whoever wants to start, prioritize services, start small, and probably pick the patient population that will be most high yield. And for instance, in my case, in my experience, I thought we picked wisely, working on the breast cancer related lymphedema patients. I wish we could do, help everybody, but I think even if between having no care versus providing some care, I think starting small and prioritizing services is important. Collaborations are important, as I stated earlier. Again, if you can't invest $500,000 for an APP and 2 physical therapists a year, and they're great therapists that you can work in the community, then work with the community. And that's how you can mitigate some of the limitations in resource allocation. Funding opportunities, I think that's very important. The Cancer Institute has a donors fund, and we have tapped on it a couple of times already. And industry can be a huge support. JUJO, for instance, has been very generous. They've identified that we serve a very challenging patient population, diverse population. We have patients that are below poverty line. They can't afford even the basics. So we have a fund and we can provide actually compression garments with no charge to the patient, thanks to our support from industry. We're very thankful for that. And then education, as I said earlier, is very important. You have to spread the word, but you have to do it carefully because you don't want to overwhelm yourself in the system. You just need to be able to pick wisely, but also raise awareness in the community. Reimbursement is a huge topic. Nobody teaches you reimbursement in medical school or in residency because, as it should be, the focus is on, learning how to become a doctor, how to do the surgeries, etc., the clinical aspect of it. But quite frankly, what I learned was if you want to build a program, unless the numbers add up, you're going to have a problem. The institution leadership is not going to continue to basically funnel resources for an unlimited period of time. So I think we've worked really hard on working on our surgery reimbursement. We can't change the laws. We cannot change what insurance can cover, but at least we can look back, see which insurance carriers can actually have provide reimbursement after the surgery. And for those that haven't, then we have contacted them. And basically, we're trying to minimize our losses from basically getting a pre-authorization and then having no reimbursement. And that's a very complex problem we're still trying to navigate. Physical therapy, we have outsourced quite a bit outside UT, so we don't have that component as strong for 75% of my patients actually receive at least part of their physical therapy outside UT. And then what happens with the non-oncologic patients, especially the ones that have venous stasis ulcers and other problems, lower extremity lymphedema? Well, now we're looking into potentially expanding and basically almost developing a second program under the wound care clinic and hopefully provide resources by combining the programs, because they already have patients that are being taken care of there with venous stasis ulcers, again, open wounds. They have phlebo lymphedema or more than one issues, and we're looking into options how to potentially grow that under a different umbrella, so it's not in the Cancer Institute, and financially that seems to make a little more sense. So what have I learned the past 3 years? Building a lymphedema program in a rural area is definitely hard, but not impossible. Our program does not compare to any of the other centers of excellence and great programs that where all the publications come from. But I think there are a lot of patients that cannot get to these centers. And I think what we have tried to do here is to try to bring that care from MD Anderson, from MSK, from Harvard, closer to the community. It's not impossible, but certainly has a lot of limitations, as hopefully you got from my presentation already. For somebody who wants to start that process, I'm happy to talk to them, and I'm open to feedback. Of course, I'll continue to stay in touch with my mentors, but negotiate during the recruitment time. I think if you want to secure equipment and resources, I think it's always easier when you're being recruited and put things on a contract. I think is very powerful, and I'm not implying you should pursue that, but if you find somebody in leadership that either themselves or they had a family member that they had breast cancer or lymphedema, or they have a family member or have a story that they've been exposed to and they have experienced that, I think this is very powerful. And you can find your hidden, ace in your sleeve. You need that person that when you sit in a meeting, will be supportive and try to help you get the resources that you need later on. I think it's very important to engage with the community. Our hospital is not able to provide all the resources that ideally I would want to build and expand the program, but we utilize resources that are available, yes, outside UT, but we work with the community, and I think that has been a very positive experience so far. I had to adjust my protocols. I didn't get into much depth in terms of PT protocols. You can't cut corners. You can't not provide, standard of care. But I had to take a step back and really add more factors into the equation when I'm deciding what surgery we'll be offering to each patient, because there are more factors that I think come into play, and that's where the adjustment of the protocols comes in. I think it might be hard, but we need to accept, I need to accept, and I keep reminding myself that there are limitations, and you can decide if you want to just say, sorry, I tried, I can't do it because we don't have the support or whatever, or you can say, well, I'm just going to try to make the best out of it. And again, that doesn't mean you cannot have any sacrifice in outcomes and standard of care, what we provide, what services, but certainly I think prioritizing all the things we discussed earlier, I think you just have to acknowledge that you just can't practice the same way, at least in my experience. I was exposed to, again, where I trained, MD Anderson. And the other thing is we can't help everyone. And I think that has been very hard for me because I may even know how to help everyone in terms of surgery, but if you don't have the right team, for instance, this gentleman had head and neck cancer, radiation, a ton of surgery in his neck. I was able to get him a pump. I was able to get him therapy, but I mean, I know what this patient needs. He needs maybe an omentum in his neck with 2 free flaps, very difficult dissection to break through that contracture. We just don't have the team to do that safely. So I had to refer him to an outside hospital. That's a very good day, actually, of him after early in the morning, but he would get massive lymphedema towards the end of the day. I think prevention is an area where you don't need a ton of resources. And even if somebody can provide immediate lymphatic reconstruction, I do believe that this is a great operation, and it doesn't require a lot of post-op care. So I think that's definitely something to consider, especially for trained microsurgeons that have access to a microscope that can perform these operations. Reimbursement is an ongoing conversation, and it's a very sore topic. I think there is great momentum. We have the Lymphedema Treatment Act. We welcome that with huge enthusiasm, and I would like to thank all the people, the groups that have worked on advocacy previous decades, basically, to get to that point. So at least now we have secured some legislation to cover to have coverage for sleeves. I think that's just the beginning, and hopefully with more advocacy, lobbying, hopefully we can raise even more awareness and get a better place from an insurance standpoint. And yes, my job is very rewarding. It's hard at times, and you have to be very stubborn and persistent, because there are going to be doors that will be closed in front of you, and you just have to find a way to just keep pushing. But when I get these happy patients and the appreciation that we get as a team, that just gets me going. So, future directions. We want to expand the program. Well, that's an ongoing discussion here, because I don't even know what's the right answer to that. Do we expand by offering more services? Do we expand by actually narrowing down the services and just saying, okay, we can't do everything. Let's just focus on these conditions, and then we'll just send the rest of the patients out. I'm still trying to figure that out. I'll be very honest with you. But we definitely want to continue to increase our volumes, to stay in the forefront, as I said earlier, in terms of techniques and protocols, etc. I really hope to expand the program, but which direction this is going to go, that's still, I think, again, a dynamic process. We do need to continue to optimize reimbursement to the best of our abilities. I realize that numbers do matter. This is something that I've learned and we'll have to continue to push as we move forward. I'd love to get our center accredited and eventually one day become a center of excellence. Like to continue to pursue our research projects. We're at a good place where our first outcomes are coming out. These prospective studies need time to collect data, but hopefully we'll be able to publish our first results soon. And then, of course, advocacy. I can't stress that more. I think at the level of DC, Congress, regional, improve CMS insurance reimbursement, and I'm just very excited to see what we can get. I know that my colleagues are working on establishing CPT codes for lymphatic surgery, and hopefully that can help with insurance coverage and reimbursement. So I think that's all I had for today. I would like to thank, well, many people, my mentors, for teaching me how to do surgeries and how to take care of these patients. I'd like to thank my institution for their support and their faith in this big project. I'd like to thank our patients. They understand, they suffer, and it's hard to explain sometimes how we have these wait lists and wait times to take care of them, but they all work with us, and we have only received love from them. LE&RN has been great. I think they great contribution to the field, and of course my family for the many evenings that I had to stay in the office and troubleshoot with things that always come up the time that you expect the least. But as I said earlier, it's a very rewarding journey. So that's my email for those that might be interested to discuss offline, or there's something that they would like me to share. I'm happy to connect with them, and I think we're going to open it up for some questions. We have a question here. It says, do you require a certain BMI for the lymph node transfer? My cutoff is BMI of 40. And we ideally wanted, some surgeons have BMI cutoff of 30. We know that that's important, but again, that's just one factor. We have to take many more things into consideration. Do you treat lymphedema patients? As I showed you earlier, we started primarily with upper extremity and oncologic patients, but as I started getting referrals and patients to reach out, we have actually taken some patients with lipedema and lipolymphedema, but again, we're trying to prioritize our Cancer Institute's needs and our hospital's needs first. But yes, we do that. Do you perform surgery for central lymphatic problems? That's a great question. Not the focus of this presentation. I think there's a ton of research and ongoing conversation on that. It's definitely something that I've encountered, but I don't consider myself an expert yet. I mentioned earlier that we're trying to build our protocols for the MR lymphangiography. Another area I'm trying to develop is imaging of the thoracic duct, which I think is very important to assess for central lymphatic problems. But I think this is an area that will expand further, hopefully, as the program expands in the future. Have another question that says, do you see patients on an outpatient basis only, or is it possible for inpatient stage 3 bilateral lower extremity treatment, if needed, is determined on a case-by cases? The good thing is that we have access to the hospital. So all my lymph node transplants have to be admitted because we have to monitor the flaps. So we absolutely have access for inpatient care. And I do not see inpatient consults because if they're in the hospital for something else, then that something else needs to be addressed first. But I see patient outpatient setting, and then we absolutely can do surgeries that require admission and hospitalization. Is it possible for homebound out-of-state patients to have initial consultation? We have done telehealth. That was actually one of the positive things of COVID, that now we have these capabilities. Is it possible to reschedule a tour site visit for networking purposes? Is there interest in networking? Yes, absolutely. I've done it before. I've had therapists and other healthcare providers come and shadow. I'm happy to show the facilities, show what we have in place, and yes, as I said, we don't have the capacity to hire another 2 therapists. So we're happy to work with the community. From rural Maine, thank you. We have many similar challenges, and our patients need to travel to Boston for microsurgical procedures. That's exactly the reason why this is important to me, and I think that's important to the community and our institution. And I'm lucky that my institution sees that as a need. We have a very strong, I guess, dedication to serve the community. And to me, it's just so rewarding when I can, even in the few patients that I've treated so far, they don't have to travel miles and miles away and relocate for weeks sometimes to have these surgeries done. So I appreciate your comment. Do you use ICG imaging? Yes, this is actually my go-to method to identify, to stage, diagnose in case there's a question, stage patients, and absolutely I map them the patients for to determine candidacy for a lymphovenous anastomosis surgery. So I absolutely do ICG imaging, and I know that we might be missing some of the lymphatics, especially in deeper structures. So I'm looking into expanding our options. But as of now, I only use ICG imaging for preoperative and intraoperative purposes. Is there any biomarker or point of care diagnosis for lymphedema? How do you differentiate different types? To my knowledge, we don't have a biomarker that we can do a lab work and come up with basically a diagnosis. I think combination of good history and physical objective measurements and imaging studies are key to differentiate between different types of edema, and sometimes they might coexist. I think we'll have one last question. I know you mentioned that you use both the SOZO and parameter. Is there one you use more often, rely more heavily on, or do you use them both for each patient combination? That's a great question. I think I have used the SOZO a little more because I think that it's more useful for my immediate lymphatic reconstruction patients, because I feel some patients with subclinical lymphedema, you may not have any change in your volumetric status, but you may have an increase in the LDEX as seen on the SOZO. So I think, and there is a lot of literature out there on that. So I think SOZO is a sensitive tool, and it's very user friendly. It also gives you a nice, easy graph, and you can follow also response to treatment. From I don't know if you're a patient or a healthcare provider, but in case you are a healthcare provider, somebody had asked me before if you had a limited budget and you need to get one. I'm not going to provide any opinion on what is worth. I don't get sponsored by industry, by any of these tools, but I will just say that the perometer is a one-time fee, and you just basically purchase the device. The SOZO, you have to pay for the device, and then you have a subscription that you need to renew. So that's something to keep in mind, I guess, in the long run. I think that will be it for today. I hope that you got what I hope I was able to share and capture what my experience has been in East Tennessee. I think there is an unmet need in more rural areas, and I think there are a lot of surgeons that are well equipped and I think would be willing and excited to work in different setup, maybe further a little bit away from larger academic institutions. And I think the more we have these conversation discussions and we help with advocacy, I think we will be able to provide hopefully better care for our patients. Thank you very much.